starting with hormones, hormone therapy. Should I do HRT? Should I not do HRT? All of this is an individualized decision. So as both of us know, and as many people know as well, most of medicine is going towards the place of an algorithm. It's like in the movie Idiocracy, when you go up and you just push a button on the machine, and then it just spits out what's wrong with you. However, in order to get an optimal care, everyone has been designed differently, and you have to pull up the scale. Everybody's scale is different, and weigh the risks and the benefits. And in order to assess those risks and benefits, you need good objective data. So the first thing to start with is good baseline labs. People like to say, well, when do you start? Do you start at 40? Do you start at 30? The earlier the better. The way I look at it is we are very complex pieces of machinery and electrical signals. And just like every car that comes off the assembly line gets tested by the computer, and if there's a problem, which often there is, even with assembly line manufacturing, that's addressed before that car is sent out to the public. Now, that doesn't necessarily mean we should be doing labs on babies, but I think at very least at 18 or early 20s, you should get your first baseline labs.
I think that that's a really wise thing to do. And when you say baseline labs, you're not just talking about a CBC or CMP. You're talking about probably getting baseline hormonal panel, baseline thyroid, perhaps even cholesterol early on to see, perhaps any kind of familial risks or things of that nature. When it comes to testosterone therapy and lab work, what do you look at for testosterone? Are you looking at free testosterone, total testosterone, sex hormone binding globulin, estrogen, for men in particular?
For men, and also for women as well, but trying to concentrate on men at the start, you can talk about androgens of all types. So testosterone is the main androgen. Just to define some terms, SHBG is sex hormone binding globulin, which is the main protein which binds all androgens and actually estrogens as well. And SHBG and other things determine, but mostly SHBG, determine what your free testosterone is. The benefits of having a high free testosterone compared to total testosterone is it's going to bind to the androgen receptor more often. The androgen receptor is throughout the whole body. It's in the hair, it's in the prostate, it's in the muscle tissue. However, when there is a low SHBG or high free testosterone, that testosterone is also metabolized faster. Testosterone and estrogen are metabolized differently. So estrogen is more likely to undergo a process called glucuronidation that we learned about in medical school, whereas testosterone is more likely to be sulfated or have a ubiquitin group attached in order to metabolize it. So SHBG kind of protects testosterone, but also prevents its mechanisms of action. So you want to balance between total and free testosterone both, and you want to check both of them. Now, to expand on this a bit, this is true of almost every hormone, especially steroid-based hormones. So cortisol, you have a total and a free cortisol. IGF-1, you have a total and a free IGF-1. Thyroid hormone, of course, you have a total and a free T3 and T4, active and inactive thyroid hormone. So I think it's important to think about the context of free and total hormones across the board, not just androgens and not just estrogens.
So that would make it really important if someone was considering TRT that they are going to a provider that's really looking at the whole picture as opposed to, say, just free testosterone and total testosterone, but really looking at the big picture. I'm sure you're seeing this a lot. I'm seeing a lot of pellet use. I'm curious as to when you look at someone's free testosterone and you're making the decision, okay, so this person is sleeping well, they're eating right, but their free testosterone is still suboptimal, right? And again, that could be whatever that number is for that individual. How would you initiate therapy in terms of, do you have a preference, whether it's an injectable, sub-Q, IM, cream?
For most individuals, my preference is injectable. It tends to have a more stable bioavailability and absorption. especially compared to creams. Now, that isn't always the case, but it is certainly possible to start on an injectable and then transition to other forms. You can transition back and forth at any time, and you can likely come off and regain your previous level.
That's
it might
really
just
important.
take a few months.
Yeah, that's actually really important to mention. People are really afraid that once they start testosterone, that they'll have to be on it for the rest of their life. Have you found that to be true?
It is definitely not true. 99+% of cases, you come off, and I'm sure we've both seen it,
Yeah.
and it might be a few months. What to do is to go to your doctor like anything else, and if you need some supplements or even medications to support regaining your natural production, then you have those administered. And what not to do is to just stop going to your doctor and come off cold turkey, because it could be months and months and months,
Yeah.
and you could be very hypogonadal.
So basically, don't be the world's worst patient and take it upon yourself. You know who I'm talking about. You mentioned supplements. For a medication, would you say maybe Clomid or HCG would really help with the testosterone production? Have you found that to be sufficient to help?
They can definitely help, and they're certainly useful in some situations. HCG is human chorionic gonadotropin, and it mimics a couple different actions. If you look at the molecule itself, it's actually very similar to TSH, which is a little confusing because we think of it as more of an LH mimetic, because it does bind the LH receptor, and it has a relatively strong mechanism of action at a lower level, especially on LH, and then it has diminishing returns as you increase. For example, if you're dosing at 700 IUs a day and then 2,000 IUs a day, you're not going to get 3 times the
and
pharmacodynamic
that's a lot. That's
effect.
a pretty robust dose if it's daily.
Yeah, absolutely.
Yeah.
Especially if it's an adjunct to TRT. Now, some of the best applicability of HCG is, of course, fertility. Both fertility while on TRT and after you come off. Not everybody that's on TRT has to take HCG no matter what.
Good point. Good point.
However, there's a few different strategies to maintain normal testicular size, so avoiding what we call testicular atrophy, especially for individuals who desire fertility. A good rule of thumb is within about a year or so, you should be thinking about being on HCG, a regimen of some sort. And before you come off, many people are able to just transition from TRT with some adjunct HCG to HCG monotherapy and not even require a SERM. The one important thing to remember in that case is HCG is suppressive at the pituitary, especially for LH and in some cases FSH. So LH usually mostly stimulates testosterone production. It also stimulates paracrine factors that go between the seminiferous tubules and the Leydig cells. But FSH mostly stimulates the Sertoli cells and spermatogenesis. So that's again, it goes back to labs. It's important to get labs to see if that's happening, because then you might need something in addition to it.
And the way that they would check is you'd actually look at LH, FSH, see if it's high or if it's low, suppressed. When someone is on testosterone therapy, how often should they, well, number one, what could they expect? So could you say, okay, you're going to start 200 milligrams of testosterone and your testosterone is going to go up by this number? Is that, can someone think like that, or it's totally variable depending on that individual?
The two analytical points to consider here is, one, the metabolism of the testosterone. Obviously, they can, different people will metabolize it at different rates, even at the same SHBG, and then the SHBG. So it seems that a lot of clinicians solely dose testosterone based upon the administration frequency and the SHBG, which again is sex hormone binding globulin that binds testosterone. So you also have to take into account the individuality of testosterone metabolism, even with the same SHBG. So over time, you can have a pretty good idea of how that happens, but it is hard to get exactly right, which is why most people pick something right in the middle of normal. Even if you're aiming for an optimal level, which, by the way, I usually consider around a total of 550 to a total of around 1,000.
Yeah, I would say that that's absolutely reasonable.
even if you want to be near the top of the optimal
Which, by
range,
the way, every single guy does, right?
Yes.
That's all, when they come to labs, that's all they want to know. What's my testosterone?
it is still very reasonable to dose near kind of the middle of the optimal range. It's like almost any other medication that's prescribed. Even if you know that it's fairly likely that you might need to tweak the dose a little bit, you try to pick right in the middle, largely just because you're much less likely to have side effects. And if you're not able to tolerate the medication,
Right.
then it's more likely that they want to come off completely. So if there's horrible sleep and they feel like they're going through puberty a second time with acne and hair shedding and prostate issues, then they're much less likely to want to continue that long term.
Yeah, that makes sense. You know, you mentioned dosing it based on SHBG, sex hormone binding globulin. Have you found a way to lower it? Just lowering the SHBG to perhaps make the testosterone more available?
In most cases, lowering SHBG is relatively easy. So adding in healthy carbohydrates into the diet is one way.